Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. The title for our program tonight is The Equality Issue in Oncology, Part 1. In 1971, President Nixon declared the war on cancer. 25 years later, after spending $29 billion in cancer research and countless publication of research data, we are losing the war against cancer. As of now, the latest statistics published in the February 1996 of the U.S. News and World Report was that except for cancer of the stomach in man and cancer of the liver in the women, the 9 other leading deadly cancers have increased sharply in terms of death rate. In particular, lung cancer has doubled in men and tripled in women during the last 25 years. So it goes without saying that we need to ask the question why we are losing the war against cancer. And to discuss this important subject, I'm very pleased to have with me 3 distinguished speakers with us tonight, and I'd like to introduce them now. Dr. Hanlon, Kate O'Hanlon. Hi, Kate. How are you tonight?
Hung. Very well.
Thank you for coming.
I'm glad to be here.
Dr. Hanlon is a professor, assistant professor of oncology at Stanford University. She has a subspecialty in gynecological oncology, which deals with cancers of the female reproductive system. And I'm very pleased to have her here with us tonight.
Thank you.
Our second speaker is Dr. William Buckles. Dr. Buckles is a graduate from Stanford University, where he also had his training in oncology. And he is an internist. He practices oncology and internal medicine in Los Altos. He has been with us before on a different panel, and I'm very pleased to welcome him back.
And I likewise, Hung.
Thank you for being here, Bill. It's good to see you.
Nice to see you again.
And our third speaker is Linda Schoeffer. Linda is a RN, registered nurse, who had been with the Kaiser Permanente Hospital for about 12 years working in critical care. And recently she left traditional medicine and became a holistic health nurse. And I look forward to ask her about the aspect of alternative medicine, which has some important implications in the treatment of cancer. So let's start with you, Kate. Maybe you can give us a quick rundown on the history of the field of oncology. When did we diagnose the first case of cancer, maybe?
Oh, good question. I think that it was described 2,000 years before the Common Era.
Really?
People have observed growths in, although cancer was much less then, because we had a lot less pollution and we had a lot healthier diets, I think. But breast cancer was described in some of the ancient writings, and as I recall, colon cancer was described in some of the ancient writings as well.
I see.
So it's been around. Treatments for cancers have not been around for very long.
Right. What are the latest statistics, Bill? You agree with the publications in the U.S. News and World Report?
The statistics that have shown an increase in certain cancers are real with regards to tobacco-associated cancers. Anything that touches smoke, whether it be from the lips down through the lungs, and then in the bladder, for example, where tobacco residues are excreted. Some of the increases in cancer are a little bit artifactual, that the screening techniques that we have been put into use since 1971, when Nixon declared, quote, the war on cancer. We've seen a wide use of mammography and now an increasing use of PSA for detecting prostate cancer.
Right.
But I think the reason that we're not winning the war is probably traceable to Pogo's comment. We have met the enemy and it is us.
Yeah, it's still a fascinating issue for me, environment versus genetics. You mentioned that there's some new developments in genetics in cancer research. Maybe you can give us some ideas to what it's about.
Well, one of the hot topics now is the soon-to-be commercially available tests for genetic tendencies for cancer, specifically breast cancer and ovarian cancer. And both Kate and I certainly will be seeing patients who will feel that they might have a genetic tendency toward these diseases based upon family history.
And it'll be important to sort those patients out based on not just their family history, but to know when it's appropriate to get the blood test. Because it can certainly be overused.
My understanding is that the role of genetics is there, but it's not clear-cut in terms of direct correlation with the incidence of cancer, in that most authors believe that there is a susceptibility of a certain group of patients with a certain genetic predisposition that make them more susceptible, but there's no clear-cut direct correlation between the development cancers and genetics. Is that true? Because, for example, they say that the environmental effects of cancer is causative agents are much more significant in that if you take a group of Japanese patients who migrate to America, the first generation have similar rate of morbidity and mortality as the people in their native land. But the second or the third generation come closer to the native-born American because of the exposure to diets and stressful lifestyle and so forth and so on. In other words, the role of genetics is not as significant, my understanding.
Well, one of the things we inherit from our parents is our eating habits and our exercise habits and our smoking habits.
Yeah.
And not just the genes that have suppressor genes for cancers and tumor recognition genes. So if you're going to smoke like your parents and eat like your parents, and most of us do, and not exercise like our parents, we're going to have the same risk for cancers that aren't heritable cancers.
That are not on the DNA,
Exactly.
but rather in the culture.
Right. That's what I'm saying. In other words, they say that, like, for the native African people living in Africa right now, whose diet is much more stable and produce, and like 80% or 70% of their calorie intake is from non-meat product. Isn't that their cancer rate is lower than in our country?
Certain cancers would be lower. Prostate cancer in blacks is much higher than it is in whites. And that is in part diet related, but also since there are many whites eating the same diet without the same early onset of cancer, there is this complex interplay of genetic factors and environmental factors. With breast cancer, perhaps 5 to 10% are hereditary in some nature. And of those, only a fraction can be determined with blood tests. Blood tests that have an immense psychological implication if you get them on an individual and her family.
Let's talk about the screening aspect of cancer a little bit here. There are arguments both in terms of pros and cons. In other words, people feel that if we do PSA on all men after a certain age, we may not be doing it optimally, in that we don't really know whether it's the cost versus the benefits balance out. You know what I mean? We can spend a lot of money screening patients for prostate cancer by doing PSA, and it's may not be very helpful.
The necessity for a screening test to be valid is that you have a useful treatment that can change the outcome when you detect something early. With breast cancer, a mammogram can change the outcome very clearly if you have early detection. With the PSA and prostate cancer, that may or may not be true. There are certainly many different kinds of prostate cancer that need further discrimination. And in fact, this work is being done at my alma mater at Washington University in St. Louis, where they are checking all nature of various biochemical and immunologic tests on prostate cancer tissue to find out if there's some other discriminator other than simply PSA.
Right.
Another factor that makes screening tests more useful than not is that the disease has to be a significant disease resulting in significant morbidity, and not all prostate cancers
Right.
are significant at the time that the PSA lets you diagnose it. As a gynecologic cancer surgeon, I see women with abnormal pap smears really frequently, and you can ignore a certain type of low-grade abnormalities on the pap smear, but you absolutely cannot ignore certain other abnormalities on the pap smear, because the cancer rate in that group of women is over 50%. So, you know, even in the PSAs could use some more discrimination as
Exactly.
like they're getting.
Yeah.
But we have that with pap smears, and we have that with mammography.
Yeah.
The mammogram can be abnormal, but not cancerous,
Right.
and require closer follow-up, so that the screening test is still useful. This is what we have to convince people of, is that the screening,
Right.
the standard acceptable screening tests are useful. They're not going to give you the diagnosis, they're not going to tell you what's going on, but they signal that this is a high-risk patient who needs closer observation, and
Right.
they need to come back or have the test repeated.
And also, prostate cancer belongs to two different distinct groups. One group is very treatable, and the other group, we don't know how it's going to happen, right? I mean, in terms of prognosis.
I'm not sure how to discriminate, how you discriminate that way. In some people, it is a very slow growing,
Right.
and if it occurs in a man, for example, in his late 80s, the competing risks of heart disease or
Right.
stroke
Right.
are such that this is not going to be a clinical problem.
Right. Right.
If it occurs in a man in his 50s, then it is likely that this will become a problem at some point.
My understanding is that there are two groups of prostate cancers that have different evolution and prognosis.
Unfortunately, we can't tell
And we can tell the difference.
pathologically
Right.
from a biopsy which
Yeah.
group that's going to be, and that's
Right.
what the research is
Right.
designed to show.
Right. Let's talk about lung cancer a second here, because that really is my favorite topic of discussion. No screening, no treatment, people smoke anyway, and you know, die by the millions. I mean, to me, it's the reflection of a cultural phenomenon, and it's not a medical question anymore. I understand that the money generated from the tobacco industry is so pervasive that, you know, maybe this jacket I wear, the air we breathe, are being funded by the tobacco industry. I mean, how are we approaching this? It's almost philosophical question.
We have to approach the populations that are beginning to smoke
Okay.
at the time that they're beginning to smoke. I mean, there's no doubt that talking to kids about how negative smoking is, every aspect of smoking, even secondhand smoke from their parents. The kids go home and they fuss at their parents for smoking, and it increases the likelihood that their parents will quit. You know, and I have to put in a plug here as a gynecologic cancer surgeon. Cigarettes are one of the major promoting factors for cervical cancer. Women who smoke have higher rates of pap smear abnormalities.
Correct.
They get cervical cancer at a higher stage, and it's harder to cure. And that's because the toxins aren't directly exposed to their cervix, of course,
Yeah.
but it gets absorbed into the blood and distributed through the bloodstream, and the cervical glands try to eject the poisons from the bloodstream in the cervical mucus, so it sits there on the cervix and just acts as a cancer promoter.
Yeah.
I think the efforts of the state of Florida and several southern states to force the tobacco industry to be accountable for the cost of their promoting an addictive drug is really laudable. I think that
Yeah.
ultimately I would like to see it politicized more. I think that there's been a tremendous service done for the promulgation of more effective breast cancer treatment with the political activism of women and the emerging activism of men with prostate cancer. I'd like to see this transcend sexual boundaries and have a breathing boundary, if you will.
Do kids know that they have a great risk of developing cancers if they smoke? Do they know?
I think that a lot of kids don't know because smoking has, to use the Alcoholics Anonymous term, a very high bottom. You don't suffer for it for the first 50 years that you do it. So it's not like alcoholism where if you get too drunk, you're going to be in a gutter somewhere when you wake up. So I think kids don't see the danger unless they have specific, tailored educational programs.
Okay. Why do they smoke?
It's
teenagers.
cool, at least in their perception, that the advertising of Joe Camel, the advertising in the various magazines and so forth, where people are doing things that look like they're fun and they've got a cigarette in their hands, or the attempt to make this simply an issue of pleasure rather than the promotion of an addictive drug. I think that the restaurant bans on smoking go a long way to giving a cultural message that this is not acceptable behavior.
Now, actually, I talked to a physician who has worked in cancer research for many years with the NIH, and he proposes that we have to have a way to create immediate adversarial effects on the smokers. In other words, people, if they have to be taught that if they smoke, 20 years later, 30 years later, they may have cancer, develop cancer, it's too abstract for them. They cannot think that far. It's cool, it's pleasurable to smoke now, so I do smoke. But if you put, say, 50% tax on cigarettes.
And on their medical insurance.
And medical insurance. Then it will hit the pocketbook immediately. It may change their behavior. What do you think about that argument?
Well, I'd be interested in how you approach health education, because I think that that's what you do professionally, is to try and address exactly those issues. How do you motivate people?
Because the effect is but not immediate. That's why they do it.
I think there's a few issues that are specific to adolescents. Part of it is that they're cool, but also I think part of it is because they're not supposed to. That gives it an additional allure. And so how do we work with their esteem and their wanting to care enough about themselves and for themselves to not make those choices. So I don't always think it's just a peer pressure, wanting to be cool kind of aspect. I think it's to act out. It's a level of acting out also.
But we as a culture define success as the movie stars who smoke, from Humphrey Bogart to the newer generation of whoever. I understand that Naomi Campbell, the big supermodel, she doesn't eat anything, but she smokes 2 packs a day, and that's cool. I mean, what are we doing about it as physicians? There's a doctor, Alan Blum. I don't know if you know of him. He's an internist, I believe, from Houston, who go around and give a lot of lectures on what he believes to be a switch over. In other words, we don't talk about how to teach people to stop smoking, but we attack the tobacco industry, the advertisement industry, and Hollywood. I think that's a very courageous stand, don't you think?
Well, and if you look at who adolescents look to as their role models, if we could have those people sending the message, also the sports figures and the musicians, the rock stars, sending the message that smoking is not cool, that may be a more accessible place to have them hear that message too.
I think your pocketbook theory is a good one, though. Frankly, if I parachute, if I scuba dive, those are lifestyle risks, and you can't get life insurance if you're a parachutist. Likewise, if I have too many car accidents, I can't get the cheapest car insurance. So, people who smoke, and this is a lifestyle problem. People say, AIDS is a lifestyle disease. Heart disease and cancer are lifestyle diseases that cost way more than AIDS ever did. That lifestyle should be taxed.
Right. Why should we, as healthy people, subsidize the unhealthy people for habits? It's not even something that they are born with that they can do anything about. I think that is compassion misplaced. I think you should attack those habits and say that we're tired of subsidizing you guys for the bad habits that you do.
It's not different than drug abusers on the street. I mean, we disdain them And I think that's a class issue, but I disdain smokers. I disdain people who have high-fat diets because they are costing Americans a lot of money.
The issue then becomes whether judgment and making people wrong will change their behavior. My personal feeling is that that's not a very effective behavior change method, is that there has to be a positive reason that the feel-good part of being fit, I believe it was Weight Watchers' comment, nothing tastes as good as being thin feels.
Boy, is that true. So how would you approach that holistically then, to make people want to be healthy?
Well, you build on what's strong in them and what is healthy in them. Taxing or blaming are very late interventions, obviously. You know, you take the person, you make them want to be the healthy person, the person inside, which is a similar Weight Watchers philosophy. I think it's a very slow process. I think that people have to understand that quitting smoking has many factors, and to be gentle with themselves and to reward the positive attempts, because it usually doesn't happen once.
I strongly believe in role modeling, though, because if there are enough people appearing on the screen who don't smoke and who don't adopt that kind of lifestyle, then things will change. I mean, I think that as a culture, people are born and raised with the aspiration to become successful people, be it movie stars or good-looking people on a fast track, and they have all the wrong habits. I mean, I think that we have to promote the kind of role models that have pleasures doing things that are not harmful to their body.
I think that so many people in our culture are stressed that the nature of pleasure has changed, is that people require such an enormous impact of a stimulus that the food has to be so rich that it gives some taste, that people have lost the subtleties.
Right.
And so until we help people rediscover what it means to be self-nurturing, and rediscover what it feels like to be relaxed and doing something on their own behalf, that we're going to be always going uphill.
I agree with you. I think that stress is the origin of everything, and obviously sometimes stress is difficult to define, because to a lot of people living in our country that promotes entrepreneurial stewardship, they feel that some stress are the stimulus for progress or civilization or whatever. But I think that unfortunately most of the time the stress is counterproductive, in that it doesn't promote any more civilized behavior or progress, but is harmful in that it disturbs the way we feel about certain things. We're not sensitive to our body anymore, like you say. The more stressed we are, we were programmed to eat saltier food, tasting heavier cigarettes, because our taste buds are numb. And the more stressed we are, the more insensitive we become to our body. And that's basically what it's about. And if we live in a more peaceful environment, then we, by itself, is a pleasure. We don't need to seek any over-the-edge kind of stimulus.
Well, how many people will undertake a stress reduction program until they're really at the edge and have some symptom that demands attention they can't continue to live with?
Yeah.
And once again, it's showing the appeal of more of a wellness approach, a healthy lifestyle. And I do think the antidote to stress is being portrayed more that way now. Less the have a drink, have a smoke, and more the go out and play, or do something good for yourself way of marketing, taking care of stress.
Well,
I think that is shifting in some ways.
The popular media, though, needs to promote healthy self-concept among youth, and parents need to be taught to instill in their youth a healthy self-concept, because that's one major source of stress nowadays. And the popular media also puts forth ideas of how kids have to be. You know, I mean, there's gratuitous smoking, there's gratuitous sex, gratuitous violence, and gratuitous law breaking on the media. And kids wonder, you know, well, should I be the way I think I'm supposed to be, or should I be that way? And that's an internal stress that allows for dis-ease. I mean, you know, how do you stop war? You don't hate war, you love peace.
Yes.
So we have to like love these solutions.
The antidote,
And I think that fear is one of the least effective motivations, though it's the most commonly used, is that people will go away from something they wish to avoid without any clear sense of going toward something that they want. And as you said, that when you go toward peace, rather than just fleeing war, you have a completely different sense of priorities, and you undertake a constructive approach. That, for example, my kids don't smoke. They don't see it at home, and they certainly hear me criticize smokers in the community. And that their diet is low in fat.
That's great.
Just because that's how we eat.
That's what's familiar.
They don't have to unlearn something that I had to unlearn growing up in the Midwest.
I think that we are already running out of time. So we need to wrap up this first segment of our show on the quality issue in oncology. I'm glad we're talking about all those preventative aspects of cancer prevention, because I think it's even more important in my mind than going to the painful aspect of surgery and radiotherapy and chemotherapy. Anyway, we are wrapping up this show. This is our 45th show, and we are touching on the aspect of prevention of cancer. And I'd like to invite you back to watch the next segment, where I will discuss with our speakers some further issues on the topic of cancer. This is Dr. Vu. Our show is America's Healthcare Crisis. Thank you for watching. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one, now that I am here. Let me be the one to be there with you through the hail and snow, so our love will grow. Let me be the one